Robert Spiera is the director of the Vasculitis Center and the Scleroderma program at the Hospital for Special Surgery in New York, which is part of the Cornell system. And Robert is a very lucky guy because his dad is one of the giants of rheumatology, and I'm a student of his dad's. I used to read his dad's stuff when I was just a pup, and I keep telling his dad, Harry, that in spite of all of his contributions to rheumatology, the most important one that he's made is Robert. So Robert's going to be talking about vasculitis in the elderly and their special needs and strategies.
Hi, thank you very much, and really thank you to the program organizers for having me here today. The only complaint I would have is it's hard to speak after Dr. Hoffman has spoken because it's very hard to be an encore to that. So I'm going to talk a little bit, and this is going to be a little bit scattered and a little bit of a general talk, but I'm really going to be talking about approaching vasculitis in the elderly. You've already heard a lot about some of the individual diseases which are relevant in many of these different populations. Some are much more prevalent in the elderly, so I'll talk a little bit about that. Let me just... So we're going to talk about a few things just by way of outline. I'm going to talk about the diagnostic implications. How do I use this? The diagnostic implications, so there are diagnostic implications of age, and we'll get into that, but certain diseases are more or less prevalent in different age groups. In fact, one set of diseases are almost defined in terms of whether you diagnose it as giant cell arteritis or Takayasu's by the patient's age on some level. We'll talk about that. The other issues that come up in the elderly are that mimics of vasculitis are often more common in the elderly. So as a specialist in vasculitis, when you see a patient, maybe that's not as complicated, but as the primary care doctor, who's really the most important person on some level in terms of the diagnosis, in terms of thinking about it in the first place, they're making the diagnosis in the elderly patient is much more complicated than in a younger patient on some level. So for example, a 22-year-old coming in with weeks of unexplained fevers and, or let's make it less dramatic than that, but some sinus tenderness or crusting or some joint pain, that's going to be a more striking thing probably than in a much more elderly patient coming in who has many chronic diseases, and among their long list of 5 or 6 things they're seeing their internist for, they mention, oh yeah, and my hands hurt and I'm congested. So it's a little bit harder for the diagnosis of vasculitis to be high on the radar screen of the treating internist before the diagnosis is ever sent to the rheumatologist. There are also therapeutic implications, and I'm going to talk about this as Dr. Hoffman did, but the relevance of certain medication side effects can differ very much whether you're a younger person, a person who's had children yet or hasn't had children yet, or whether you're elderly. And I would argue that the susceptibility to certain side effects differ, and I find that that's particularly true for steroids. And this hasn't really been quantified, and we'll talk more about that, but I think there are certain steroid side effects that pose unique challenges in the elderly that really factor into our thinking about how to use them in that population and whether other drugs should be used to spare steroids. And then again, as I said, the idea of comorbidities. Older people are more likely to have other concurrent medical problems. So a 75-year-old coming in with vasculitis is more likely to also have hypertension or diabetes or a history of heart disease or hardening of the arteries. This can both confuse things diagnostically, it can make it more complicated to know when a problem arises, whether it's a disease-related thing or whether it's related to one of their other medical conditions, and I'll talk about that. So again, we know there are many different clinical syndromes. This is from the American College of Rheumatology slide collection. There are actually many more vasculitides than these, but some are more common in certain age groups than others. And what I'm going to focus on a little bit is giant cell arteritis or temporal arteritis or cranial arteritis. Those are different names used for this. And this is one of the large vessel vasculitis syndromes. And in fact, it's probably the most common vasculitis that we see. And often vasculitis specialists aren't even the people primarily taking care of this, because this is often cared for by the general rheumatologist or sometimes even the general internist. When I give lectures to general internists or to physicians, and it's sometimes an overview of vasculitis, so much less specific talk than this. Maybe it's I'm doing an hour on vasculitis and people are talking about everything else from osteoarthritis to hypertension. I really focus a lot on this because this is the one disease that internists are pretty sure to see. Many internists will go through their career and maybe not see a Wegener's granulomatosis or a cryoglobulonemic vasculitis, but most of them are likely at some point to see giant cell arteritis, and probably more than once. And again, when we talk about vasculitis in the elderly, when we're thinking in terms of the approach, giant cell arteritis is relatively common. Again, I'll talk more about that. Small vessel vasculitis, as you heard before, things like Wegener's granulomatosis or microscopic polyangiitis or Churg-Strauss, they can occur de novo. They can occur, for the first time in a person who's elderly, but it's a little bit less common. So when you see somebody coming in as me as the rheumatologist, the patient's been referred, there's a concern that they might have a small vessel vasculitis. Often in the elderly patients, recognizing that these diseases are less common in that population, I'm really thinking of other things that might be operable here. And actually, I'll just scatter some anecdotes. I actually saw a patient, this is about 3 years ago, who was 78, and he was referred with biopsy-proven small vessel vasculitis. He also had something called rheumatoid factor that was detectable in his bloodstream. He didn't have rheumatoid arthritis. The biopsy had just been done by a dermatologist. He had had weeks of unexplained fevers intermittently and just sort of failure to thrive. He felt somewhat achy, but not anything localizing. And during my evaluation, he happened to have something called a rigor while I was examining him. So he was coming in, referred to me as vasculitis with a pathology report saying this patient has a small vessel vasculitis. He has leukocytoclastic vasculitis. He had this rigor while in my office, and I did blood cultures, and I'm admitting I might not have if he had not had that rigor, and they grew actually a very dangerous species of bacteria, and we found the source of the infection. So he had something called subacute bacterial endocarditis. So again, it was just very pointedly made the point that you have to think of other things when you see small vessel vasculitis in the elderly. And in fact, an elderly patient seeing this diagnosis for the first time, I think likely would want to have a specialist consultation, where frankly, giant cell arteritis, which is relatively common in that age group, they might even, and can be proven by biopsy, which is often, I would say on some level, more definitive, you're more comfortable with the diagnosis. So again, this is again from the American College of Rheumatology slide collection. This is a patient who you can see is not very elderly, but probably in his 60s, has these bulging, prominent temporal arteries, which are tender and painful. And this is really the disease. This is a picture of somebody with this disease called temporal arteritis. The clinical features would be, they could actually present in many different ways. Sometimes it's systemic symptoms. I feel achy, I feel soreness in my shoulder and thigh girdle. They may have been losing weight. They may have unexplained fever, but they might not have any of those more systemic symptoms and have more localizing symptoms, like headaches would be the main symptom that you'd be concerned about, or the most frequent, I think, presenting symptom with this, that a patient may complain of severe headaches, but a headache that's more severe than other headaches or qualitatively different than other headaches. Again, I was saying before, before, this patient walking into their internist's office who has hypertension, diabetes, had a coronary stent, let's say 2 years earlier, the internist is seeing him in his, yearly or tri-yearly visit, saying, well, let's go over your list of problems, and at the end the patient might be saying, yeah, and I'm having these new headaches that are really bothering me. It's not hard for that diagnosis to be missed at the beginning. Take some Tylenol, try some Advil, maybe they get on other migraine medicines, maybe they get an MRI of the brain and they're reassured that they don't have a brain tumor. So you would not see this diagnosis in general with a normal MRI of the brain. So again, the comorbidities in this patient group can often lead to the internist missing the diagnosis, but it's a relatively common disorder. So again, as I mentioned, this is one of the large vessel vasculitides, and I think this group is familiar with the fact that we often break down our different forms of, there are different ways to classify vasculitis, but one looks at the size of the blood vessels involved. Giant cell arteritis, like Takayasu's that you had heard about earlier, which is a very similar disease, and Gary in certain moments argues that maybe it's the same disease, in certain patients at least, is one of the large vessel vasculitides, and it's relatively common. If you remember the prevalence numbers that Gary mentioned for, I think, Churg-Strauss, this is orders of magnitude higher than that in patients over the age of 50. And it's an interesting disease in that it's potentially organ-threatening if it's left untreated. So that patient coming in with the headache is miserable because of the headache. They're miserable because the achiness, if it's there, or the fevers, if they're there. But the danger of this disease mostly is that it can cause compromised vision. Some of the blood vessels that get inflamed go to the eye, and if those, they can essentially cause a stroke of the eye. And once you have that damage, so this concept of damage again, once that is incurred, it's irreversible. So vision loss is irreversible. Other stroke-like things have been described, but that's much, much, much less common. And in fact, I'm more concerned about that in the Takayasu's patients, but we'll get to that. The other thing about giant cell arteritis is it's very easy to treat it, at least up front. So steroids are the mainstay of therapy for this disorder. They're pretty much invariably successful in terms of bringing down those inflammatory markers, much like occurs in Takayasu's that you heard about, but they're morbid. They carry a high burden of side effects, particularly in this population. And it's also been recognized that there are late complications of temporal arteritis. So I often reassure patients with this disorder that once you get through those first month or several weeks of steroid therapy and you've not incurred organ damage in terms of vision loss, it's very unlikely that you're going to have vision loss from this disease. Number one, we know the diagnosis already. We know what to look for to lead us to raise the steroids if we need to. But we recognize now that there are late complications. These patients are at higher risk for other large vessel complications, so aneurysms, which are these outpouchings from the large blood vessels, which can occur anyway in this population, are even more prevalent in patients with this disease. So again, there are, in terms of the impact, the systemic inflammatory manifestations that you present with, the achiness, the fatigue, the fevers, those are easy to control. The ischemic complications like vision loss, you have to prevent. And once you've suffered them, they're not usually going to be reversible. But I would say what we struggle with as rheumatologists, a lot of this stuff happens before we even meet the patient. It's when the internist is going through the evaluation, and they often do think of it. We're often dealing with the morbidity of therapy, particularly steroids, and these late vascular complications. Again, getting to the idea of difficulty in diagnosis, this is a slide talking about the likelihood of aortic involvement. So remember, there are many large blood vessels. Dr. Hoffman showed you the branches off the aorta being involved in Takayasu's arteritis, which is a large vessel vasculitis. The aorta and its major branches can be involved here as well. And if you look in patients, even with very early disease, There's evidence by CAT scanning of aortic wall thickening in up to maybe about 50 to 45% of these patients. But if you look at age-matched controls, maybe about 14% of them will similarly have vascular changes in the aorta and its branches. So again, it gets into the issue of if a patient doesn't have recognized temporal arteritis, but they're being evaluated for fevers and whatnot, and somebody gets a CAT scan and finds that they have aortic aneurysms or aortic wall thickening, that can be seen without it being this disease. So again, it's not necessarily going to be right on your radar screen as an evaluating physician. So again, this whole idea of comorbidities confounding diagnosis is complicated in this age group. As I mentioned before, we also recognize that there's increased risk of aneurysms at follow-up. And this is an old paper, a relatively old paper, showing that there was a 17-fold increased risk of thoracic aortic aneurysms in temporal arteritis patients compared to age-matched controls, and a 2.5-fold increased risk of abdominal aortic aneurysms compared to controls. And frankly, often I see these patients only a few times, and they're followed by their internist or local rheumatologist, and one of the questions is, well, how do we screen these patients down the road? And I don't think we've defined that, in terms of these are still relatively uncommon events, but we haven't really, as a vasculitis community, really defined for our colleagues, how should you search for these aneurysms at follow-up? And I think there's work being done to look at that, to try to address that. The other issue, so spinning that around the other way. So let's say somebody's had temporal arteritis and they're 5 years out and they're being followed by their internist, and in the course of an evaluation of something, they're recognizing as having an aneurysm in their lower aorta. We don't know for sure that that's related to temporal arteritis or not. There are ways to try to address that question. There are different imaging modalities that might be helpful. Labs might be helpful if you find a high SED rate or CRP. But we have to remember that large vessel vascular changes might be related to vasculitis, but they might be related to vasculopathy. So not every abnormal blood vessel is a vasculitic blood vessel, and that's relevant in younger patients as well, but given the higher prevalence of things like just hardening of the arteries, atherosclerosis in this older age group, that becomes very relevant in terms of assessing them. And it was interesting, even when Dr. Hoffman was showing a slide to just demonstrate angioplasty, he took a slide that had samples from atherosclerosis, and often in evaluating these patients, we have a hard time teasing that out. There are ways that good radiologists might be able to do it, but it's again, it can muddle the approach to patients. This is a patient with an aneurysm who has giant cell arteritis, so this is a thoracic aortic aneurysm. This should not be as prominent there as it is, and this just recognized and followed up a routine chest x-ray some years later. You heard a lot about Takayasu's in similar films even talking about aneurysms. So again, focusing this talk on approaching the elderly patient, it is relevant to have a little bit of a discussion of the idea of giant cell arteritis. And by the way, these are slides I borrowed from one of Dr. Hoffman's colleagues, Carol Langford. This is actually a patient, I believe, with giant cell arteritis with involvement of their subclavian vessel. But I can include this in a talk about Takayasu's arteritis as well. And to make it even more complicated, there are some patients with temporal arteritis who do not have temporal artery involvement. They really, for all intents and purposes, have disease that looks very much like Takayasu's arteritis. Yet if I wanted to enroll them in one of Dr. Merkel's registries of Takayasu's, I couldn't because they're 60. So some of it is semantic, and it's not clear to what extent giant cell arteritis and Takayasu's are unique entities, or are they part of a single spectrum? And I think at least in some subcategories, they are really part of a single spectrum. Again, there are these many shared features to the two. There's large vessel involvement, both respond to prednisone, both struggle with the toxicity of prednisone, but I find that a greater challenge in the elderly patients, although in the younger patients, I think there's a longer duration of disease, often, if for no other reason, because of their young age, so often we're struggling with that as well. And again, the relapsing nature of the disease, and again, both of them are granulomatous forms of vasculitis. And again, this gets into there are differences between the two syndromes, but the most striking one is age. By definition, temporal arteritis, we usually appreciate it as being people over the age of 50, whereas Takayasu is usually patients that are under 30. But again, diseases aren't defined by an age. A person's disease is their disease, and these are all clinical diagnoses for the most part, and there are overlaps that are relevant in terms of how we approach the patients, and that would be beyond the scope of this talk. And again, I was mentioning this before, large vessel disease. So I was speaking at just a vascular medicine workshop the other week, where nobody was interested in vasculitis. They wanted me to give a little blurb about vasculitis, but we pointed out that large vessel disease can be inflammatory, as in giant cell arteritis, the most common vasculitis in the elderly, but almost every elderly patient has some degree of atherosclerosis. They might have thrombotic or embolic disease, so blood clots and things like that in arteries. So it can be very difficult to distinguish this, and in terms of approaching the patient with a vascular abnormality who's elderly, you have to keep these things in mind, both when you're evaluating them initially or when they come in a few months down the road and maybe they have a less strong pulse on that side. Is it really inflammation or is it atherosclerosis? And again, in the elderly, mimics become very relevant. Atherosclerosis, thrombosis, certain drugs that can induce vasculopathy. I'm hoping that in most elderly patients, cocaine is not particularly a concern, but it can. This is really probably more relevant in our younger patients. But again, infection very much can cause vasculopathy that's not vasculitis. So that's talking a little bit about diagnosis and what are some of the unique issues that looking at an elderly patient with vasculitis may affect our initial diagnostic evaluation. But the other thing that happens in anybody with vasculitis is it's always an ongoing process of assessment. You're constantly assessing these patients, and there are a couple of concepts that we really use as clinicians to help us. And the two concepts that are really important in vasculitis assessment, which you've really heard already this morning, but I'm just going to summarize here. One has to do with disease severity. So we think of severe versus limited disease. This is a term we've used in some of our trials, but we're always thinking this way. So Dr. Hoffman before talked about, he mentioned that some patients with Wegener's really don't have imminently life-threatening Wegener's or organ-threatening Wegener's, and you might choose milder medicines. We also think about disease activity versus damage. So a patient with Wegener's or microscopic polyangiitis that has a creatinine of 4, the fact that their creatinine is still 4 a year later doesn't mean they still have active Wegener's. It might be damage that was done, and the clinician has to know not to chase that with more immunosuppressive therapy. So these principles apply anywhere from the first talk to children to people of reproductive age to the elderly, but it becomes a little bit more complicated in the elderly for a couple of reasons again. Number one, comorbidities mean that they often have, which means the other medical problems that they carry with them means they are often more tenuous in terms of their general health. And we don't want anyone to lose any ground at any age, but very often in an elderly patient, there's much less room for damage. So this is true in anyone, but an elderly patient is more likely to come in de novo with a higher creatinine, for example. And another 20% decline in renal function in that patient might mean dialysis, whereas in a 20-year-old who was playing football the week before, it probably, they could sustain a 50% decline in renal function without probably, if no further damage occurs, having it impact their life in that way. So in the elderly, we have to think about that. And the other issue is, we're doing better. You looked at that slide about a 70% 3-year mortality with Wegener's if we looked at patients in the 1960s, and now we're doing much better. But that also means that these patients with small vessel vasculitis are living into their 70s and 80s. So there's been more cumulative damage that becomes relevant, both related to medications that they've seen in the past. Maybe they're 3 years of cyclophosphamide in 1970, being relevant down the road, maybe their repeated courses of steroids, and also treatment flare-related damage. Maybe that little bit of renal insufficiency from the few flares over time can catch up with them. So these become really important considerations as we think about these patients, and we should be thinking about that in our younger patients who we know we're confident are going to be with us, hopefully, in 20, 30, 40 years. I also want to mention therapeutic considerations. And again, you always have to individualize therapy in anything in medicine, ranging from something as mundane as hypertension to these very complicated disorders. But there are many considerations that become relevant. So just like compliance was an issue in younger patients, compliance, meaning the patient is going to take the drug that you're asking them to take, becomes very much an issue in elderly patients, often because they're on such complicated medical regimens that it's difficult for them to keep it in line. Often there are financial issues. They might not have insurance that covers medicines, and they're just not mentioning it to people. So compliance becomes a big issue. Polypharmacy becomes a big issue, meaning the patient is on multiple medications. The 25-year-old with new vasculitis is coming into you likely on nothing. The 75-year-old coming in to see you with new vasculitis is almost certainly going to be on some medications for something, and we have to think about that as we prescribe medicines, and we have to keep this as a very live thing with each patient visit in terms of making sure we're up to date on what they're taking. And I would also say that if electronic medical records are good for anything, this is what I think they're best for, is just keeping an updated medical list on everybody. I talked a lot about comorbidities affect our choices of medicines. We have to think about access to medical follow-up and logistics. I like to check CBC's blood counts on patients on cyclophosphamide sometimes every week, sometimes every 2 weeks at the outset. Some of my elderly patients can't do that, especially this past winter. You know, people coming in or even getting to a commercial lab locally, and I have to think about that if I'm on the fence between maybe giving them rituximab or cyclophosphamide as I treat them, the fact that it'll be hard to get blood counts every other week, and that's more of an issue often in the elderly patient. Family involvement is a huge deal, and that's often a positive, but it can sometimes be a negative when you're treating the elderly. The elderly often, and also I don't know what we mean by elderly. You know, so I'm pushing 50 now, so I don't, 20 years ago I would have thought about me as being in that category almost, but it's really, yeah. So it's really, it depends how you approach that, but certainly in the very elderly, often these patients are very intelligent, very aware of the issues, and sometimes it almost becomes a pediatric discussion with the family, but they're not pediatric patients and they really should have ownership of their care and the decision-making processes, but it's very difficult. These are well-meaning family members, and this is often a challenge for us as clinicians in terms of what the right lines are and who should be making decisions, especially when there might be cognitive changes evolving over time, which is one of our main challenges taking care of these patients when you've known them long term. And then finally, probably more so, when a pediatric patient comes in, the pediatric rheumatologist basically becomes, for all intents and purposes, their primary care specialist. That's not always true in vasculitis, although in the elderly, although on many levels often we are, but coordinating things with their other specialists become important. Other than these big stroke issues, there are some very, specific toxicity considerations that are different when choosing medicines in the elderly than in younger patients. Steroids I'll talk about a little bit, but I would say there's a greater sensitivity to side effects in the elderly, and I'll talk about that. Cytotoxic or immunosuppressive therapies, I would argue on some level, can be easier to use in the elderly. So I'm less concerned about infertility in an 80-year-old than I am in a 28-year-old. I'm frankly less concerned with late malignancies 10 years down the road in an 85-year-old than I am in a 20-year-old. And I'm not concerned about pregnancy implications. I'm not worried that they're going to get pregnant while on methotrexate or leflunomide or mycophenolate. But I'm more concerned about other things like bone marrow suppression, especially somebody who's seen cyclophosphamide before, or infections or lowering of counts. So there are unique therapeutic considerations that come into mind based on not just the patient's chronologic age, but almost their general health. So this is a little generic to general health rather than chronologic age, but chronologic age also often brings these other issues with them. So I'll talk for a couple of minutes about steroids specifically, and you guys have heard this a lot and know it, and many of you have lived through this. They're the mainstay of therapy in most of the many of the vasculitides. It's the only proven effective therapy in the most common vasculitis in this age group, giant cell arteritis. Side effects are common, and they're generally related to dose and duration of therapy, and many side effects can really be mitigated by monitoring and treating for these complications. So this is from the PDR, just a slide showing the many side effects of prednisone, but I'm going to focus on a couple. Osteoporosis, myopathy, skin fragility, and neurocognitive issues, things like psychosis, neurocognitive impairment, or depression, which I think are particularly relevant in the elderly patients. So these are the 4 things I want to focus on a little bit. So corticosteroids definitely adversely affect bone health, and we're all very familiar with this, but it took us a long time to know how to do this right. But the first piece of that is just paying attention to bone density. So many patients now have had a bone density done. This is a bone density. This is in a 70-something-year-old who indeed is osteoporotic. This is what a bone density measurement in the hip looks like. This T-score of minus 3.6 defines this person as having osteoporosis. They're at increased risk for fractures. If that test has not been done, it should be done. And if it has been done, it should be repeated at periodic intervals while on steroids. You have to verify adequate calcium and vitamin D supplementation. You have to look at concurrent medications and use them when appropriate, things like these anti-resorptive agents, things like alendronate, which you know is Fosamax, or other anti-resorptive drugs. There's some newer anti-resorptive drugs. There are these anabolic agents like terapeptide, Forteo, which can build bone, but these things often really can mitigate steroid-induced bone loss, and that's actually relevant in young patients as well, but since the older patient is starting from a lower starting point from bone density standpoint, we need to be particularly vigilant. And then the other thing we often forget about is talking about fall reduction strategies. That's more important probably than just strengthening bone, and especially in your temporal arteritis patient who may be blind or partially blind in one eye, you really have to pay attention to that. And strengthening exercises, sometimes physical therapy, environmental accommodations, getting rid of throw rugs in the apartment, those things are probably as effective interventions in reducing fracture risk, which is what we ultimately care about. I don't care what the test shows. I don't want them to be having fractures. So you have to be particularly vigilant in the elderly. The second thing that I'll talk about, and again, there's many side effects of steroids, but these are the ones that I think are particularly relevant in the elderly, is steroid-induced myopathy. Myopathy means sick muscles, and I actually think this is something that's ubiquitous, that always happens with uses of high doses of steroids, especially for a prolonged period of time. I think it's one of the major sources of morbidity, meaning harm to their general health in patients with vasculitis on steroids, and it really impairs them in their ADLs, their acts of daily living. And often this is just a general kind of weakness, often in the hip girdle. They're not really complaining of pain, but they're having a hard time getting up from a chair. They might be having a hard time getting off a toilet, transferring, and I really think this is probably inadequately discussed up front because we're talking about chemotherapies sometimes, and we're talking about infections and all of the other things from steroids. I think this is really an important thing, and often these patients feel like they're still sick, and it's not from the disease, it's because of steroid myopathy. They're just not functioning well, and it's because of this, and I'd like to see this better studied. And it's reversible, so as you wean off steroids, it can be reversible, but it takes a long time. Next, I'm going to mention skin fragility, which actually is really one of the things that seems a little bit more unique to the elderly. These are photographs of elderly patients treated with steroids, and this sort of bruising or even frank breakdown of the skin happens fairly frequently. And even some of our patients not treated for very prolonged periods of time seem to be susceptible to this. These patients are often on antiplatelet drugs like aspirin or Coumadin, which can exacerbate it, but it's really a major issue. It's not just a cosmetic issue. It increases the risk for infection. We don't really have any therapy for it. We teach patients how to manage it. We're vigilant for infection. We sometimes put on shin guards and things like that just to prevent breakdown in really thin areas. And it can be exacerbated by fluid retention and edema. But again, a very common thing, very unique to the elderly, and I think it should be talked about up front because patients, it really affects their quality of life. Unfortunately, we don't have any preventive strategy for this. And then finally, and I'm not going to get into this in great detail because I'm running long, neuropsychiatric issues are a major issue in patients on steroids in general, but especially on high doses of steroids that we use in the elderly. Depression, it can unmask things like depression, mania, but cognitive impairment I often think is unmasked when people are on higher doses of steroids. And it's not to be confused by central nervous system involvement with vasculitis. I would say I've seen a consult maybe a few times a year, an elderly patient with giant cell arteritis not doing well, maybe never quite normalized their SED rate, and they're neurocognitively off. And their docs have left them on maybe 20 milligrams of prednisone for a prolonged period of time, and their concern is that maybe there's central nervous system involvement, brain involvement with vasculitis. And these can be palliated. There's certainly things like depression and mania can be palliated by adjunctive medicines, serotonin uptake inhibitors, things in the Prozac family sometimes can be helpful, but it's mostly a matter of lowering the prednisone and having a high index of suspicion for this complication. So again, that was really a smattering. I talked a little of our approaches, how being elderly affects our approach to the patient, the impact on our approach to the patient. So I talked a little bit about diagnostic considerations and treatment considerations, and really the essential role of communication and coordination of care in this group of patients, maybe more so than your 30, 40, 50-year-old with vasculitis. But although the title of this was in the elderly, we are always individualizing treatment plans and tailoring it to the particular needs of the individual patient. And really, in a way, that's what this forum was sort of organized to point out. Okay, thank you.